Thank you for this kind introduction. You've been at this for almost 10 hours now, and I hope that I can keep you awake. I have a lot of pictures and a couple of new concepts. We'll start with this 81-year-old lady who comes with a new access in December, 4 months after it was created. She's had a number of previous accesses that worked for her for a while and then failed. And this is the angiogram that you can see here. It's a right upper arm, and you can see that there are two little narrowings in the inflow segment as well as at the arterial anastomosis, and then there are a number of valves there. So when you have somebody, her age group, with that kind of presentation, the first question that will guide us to most of the fistula presentation is, do you think this is usually a problem-free access? It's a fistula. Does it usually not mature? Or, what is the typical type of stenosis that she has? Does she have, at this point, the typical type of stenosis? Is steel at all a problem in her? Most of the board questions don't really have a good answer, so I'm going to just go through those 4 options and present the evidence or the way of thinking about it, and so you can come up to your best answer. So is this usually a problem-free access? Well, it turns out this is what developed over time in her. She has a terrible stenosis at the cephalic arch, then the entire cephalic vein shrivels up. The needle insertion segment actually looks pretty good, and the inflow segment has this chronic, stable inflow stenosis. And you can see that she undergoes 10 plus procedures over the next 2 or 3 years until she reaches some kind of equilibrium with extensive stent graft placements in the outflow. And I call this chronic access disease that is really a result of what we try to do with an access creation. There are pre-programmed sites of stenosis where you find a lot of turbulence. Depending on the access, it's at the anastomosis, cephalic arch, swing point, or at sites of side branch ligations. There is an increase over the lifetime of the access of the artery due to shear stress, and so more and more blood is delivered to the vein that then has to deal with it. Intermittently, some accesses thrombose. Once you have thrombus exposure, you start a biological cascade where the vein thinks it needs to scar down and die. Then there is a component of injury that you cause with an angioplasty balloon. If you start using devices like stents, then you get stenosis at the edges that then after 6 or 12 months need to be treated. And the needle insertions themselves, depending on how the pressure is in the access, cause changes in the access with aneurysm formation or stenosis. If it's always at the same time, the needle tips can cause stenosis. So it's not a problem-free access. There's a 60% chance this will not mature. Well, if you think of broad categories of accesses, there are those in green that are created and then they go on and have nice flow. There's another category in blue that you create and then they wither away and die and they're gone. And then there's this middle category that is still there, but it really is not usable to a variety of factors. Part of it is low flow in the context of a stenosis here or there. And if you look at the largest randomized study that has ever been done in this area, about 60% or more of fistulae fail if you don't intervene. If you do intervene and you fix stenosis, and these are abstracts and papers that were published, then you can get 90+% of these non-functional accesses to a state where you can actually use them for dialysis, and 70% of them are 12 months in these studies are still usable, and it really depends on how closely you follow them, how much are you willing to invest in surgical or interventional real estate that you can keep those accesses going. There is undeniably a role of a surgeon. So in that Denver study, each surgeon only created about 3 accesses over the course of per year over the course of the study, which seems low, but it's probably just a marker that these surgeons involved in the study weren't doing a lot of access surgery. If you look at European centers, Germany, Klaus Conner, or in Britain, the group of Chemla, where the surgeons do way above 100 accesses per year, they have maturation rates and success rates at 1 or 2 years of 80+%, even in very complicated patients. So finding the right surgeon often is the problem that most of the Americans have. Now, how can access maturation by an interventionalist look like? So here you have a patient presents 20 days, less than 3 weeks after surgery with a faint thrill, left upper arm access. You can still see the incision on the right of the image. And if you look on the inside, you have this little tiny squiggly vein that has like a near total occlusion in the beginning. And can this be fixed? Well, if you start slow with a small balloon, and then you bring the patient back here, 3 weeks, 4 weeks after the first intervention, you do another one, and then you end up angiographically with a nice access that has 7-8 millimeter diameter. It has flows in the 1,000 millimeter per ml per minute range, and the access is successfully usable for many, many years with interventions once or twice a year. So it can be done, but you have to kind of get the biology right and trigger the vessel into maturation. It leads us to a question, well, what makes a good access, right? In your book or my book. In my book, you want to have 3 things. You want to have an inflow that delivers enough blood for dialysis. You want to have an outflow that brings it back to the heart without any problems. And you want to have a segment that is large enough for repeated durable needle insertions. You want to be able to safely insert and remove needles. So if it's too pressurized, it'll bleed. If it's too soft and it can't augment the access, you'll just perforate all the time. You want to have a blood flow rate that is 50 to 100 ml above the desired blood pump speed. And we're all pressurized for short treatments, but sometimes if your access only delivers 400 ml per minute, you may have to say, well, dialyze 4 or 5 hours, but you get good clearance. And the absence of clinical steal symptoms, where you don't want ischemia in the hand, and you want to have intra-access pressures that are conducive to long-term integrity of the overlying skin. In our hands, this is the reason that accesses fail long-term. All right. So here is the historical experience of the typical Brescia semino fistula. Access has been used for 25 plus years, has great flow, has at the elbow, you see that the vessel from the forearm diverges into 3 vessels, cephalic, basilic, and brachial veins outflow. So what you do is you lower the pressure in the access and allow and have long-term low pressures in the access. You still develop needle insertion site aneurysms over long-term, just because with the arm hanging down, you get a little bit of distension, but these aneurysms or needle insertion sites are really soft, the skin is intact, it's not thinned. And when you listen, you get this deep, grumbling, continuous flow, because the flow is relatively high, but it's continuous. If you were to create an access that doesn't have that multiplication of outflow veins at the elbow, and sometimes nature gives you an example here where you have a radiocephalic that does not have an outflow other than the cephalic vein in the other upper arm, then you get an accelerated skin breakdown, you get aneurysms, you have the need for procedures, which the other access did not have, and in fact this patient then died from a skin-related infection of his access. In the US, in the context of fistula first, we have been able to shift our accesses from a lot of grafts to mostly fistula. We're over almost at 2/3 now. But what that has come at is at the price of moving accesses from the forearm to the upper arm. That means you have larger inflow arteries, and the outflow veins that you use, it's the cephalic vein or a transposed basilic, is a tube that does not have a multiplication of outflow veins up to the central vein, so you have accelerated skin breakdown and enlargement of the accesses over time. And the concept here is that with an upper arm access, you often have a single tube, so a stenosis immediately increases the pressure in all parts of the access, versus a network in the forearm, where you may even often have small side branches that can dissipate pressure. And the flows on average in a forearm access are much lower when you start out, because the arteries are smaller, and that's where a lot of the pressure drop appears. Next part of our question was, well, this is brachiocephalic vein fistula that we looked at in the beginning. What's the typical site of stenosis? And the patient presented with an anatomic inflow stenosis, but then over time, really, the recurrent issue was the cephalic arch outflow and the cephalic vein stenosis. And if you think of the major types of accesses that we have, grafts usually have an outflow stenosis. Forearm radiocephalic vein accesses usually present with an inflow stenosis. Usually the multiplicity of outflow veins makes that clinically non-important, but the inflow stenosis limits the flow, which becomes then apparent in our setting where we have to have relatively high flows for dialysis. I talked about cephalic arch and upper arm brachiocephalic vein fistulas, and then the swing point segment in a transposition access where the basilic vein is basically mobilized through the fascia is often a point where you have a stenosis. This is here graphically captured, about 55% cephalic arch stenosis in brachiocephalic vein fistulas, and about half of radiocephalic vein fistulas present with a stenosis that's hemodynamically relevant. A lot of brachiocephalic vein fistulas have an inflow stenosis, but it's not hemodynamically relevant, so it's really not counted here. Grafts, 2/3 of stenosis are at the venous anastomosis or in the immediate vicinity. Now, how do you then figure out which of your accesses need attention or need an intervention, need imaging? You can rely on monitoring or surveillance techniques, but it turns out that expert physical exam is often as good or sometimes better than those techniques. So when we looked at one of our dialysis units and asked the nephrologists, well, to identify are their accesses well functioning or not, most thought, and so you see the two columns, there are 60 fistulas and 55 were thought to be good, and there are 14 grafts and 12 were thought to be perfectly fine. But then if you actually go with very, with categorized physical exam, and you look by somebody who does this a lot, then you find that there's actually a lot of dysfunction in these accesses. And usually in this study we could angiographically confirm them, and we could improve the physical exam finding by interventions. And the question is really, well, do the nephrologists have no time to look? They say, well, it's all taped up and I can't feel it. Or is it that they don't have expertise? And when you walk out of here today, you'll hopefully have the expertise, or you have the tools to acquire the expertise. So there are 5 elements of the access exam that I would like you to kind of appreciate and possibly practice as you go along. It's the pulsatility that is really a measure of the pressure in the access with each heartbeat. There's a thrill, which is typically a transferred turbulence that is physiologically present at the transition from artery to vein at the anastomosis, but is also present at every site of stenosis along an access. Similarly, augmentation, it's the single most important factor to start or to allow cannulation in a safe manner. If the vessel cannot augment and become firm, then needle insertion invariably will lead to penetration injury and infiltration. And that's the most common thing with immature accesses, that they don't augment properly. It can be with a severe inflow stenosis, but it's usually due to a variety of collaterals. You all have used stethoscopes to listen to a murmur or bruit, and though there can be, the question there is it continuous versus non-continuous? Discontinuity would suggest that you have a stenosis in the inner outflow that stops the flow during diastole when the pressure is lower, and then there's a pitch change usually at the site of stenosis. Lastly, what you can test with collapsibility of the access is how are inflow and outflow matched. Is the capacity of the outflow large enough to take up the amount of inflow? So here's an example captured on movie for pulsatility. It's a left forearm loop graft, and so you can focus on this place where the skin seems to be jumping at you this is increased pulsatility. And in this case, there was a near total outflow stenosis, and once that was relieved, then you don't see that anymore. Here's an example of a patient that where augmentation comes in. It's a left upper arm brachycephalic vein fistula is created, started using it, and they infiltrate time after time. So a fistogram is done, and it shows that there's the normal outflow through the cephalic arch, but there's also a very large side branch to the forearm. So every time the nurses apply a tourniquet to the outflow, all the blood inflow dissipates through the forearm outflow, and the vessel becomes soft, and needles basically penetrate once they go through the skin. So the clinical solution here is just to use a tourniquet below the elbow, shut off that forearm collateral, and use a second tourniquet in the upper arm. Thereby you pressurize during needle insertion the access, and things are fine. Very often, over the course of a lifetime of an access, these collaterals, they close off, as happened in this case. Here's an access, again, non-maturing, left upper arm access. You can see the scar. It's about 3 months after creation. And you have increased pulsatility at the anastomosis. You have a thrill right at the anastomosis. When you occlude the outflow, augmentation is diminished, and there's a discontinuous flow murmur in the juxtaanastomotic segment. So that constellation of findings is typical for juxtaanastomotic stenosis. And so here you have a flow murmur that is not really continuous, but it has a harsh component, it has a little bit of a high pitch component, and it almost stops. Yeah? So this is the angiogram to this. You can see the 2 near total occlusions indicated by the red arrow. Just again, put this sound in your memory bank. And then we do an angioplasty, single one. You can see the flow increases from less than 400 to 1200. The size of the vessel within less than 3 weeks increases under shear stress conditions and no release. And you get this. It's like a pretty loud ocean wave. Usually when I can adjust the sound, but it's continuous. Yeah? There's the harshness is gone. It's truly continuous. So this is what you're looking for. The last example is one of collapsibility. Right forearm radiocephalic access. You see this vessel. It's 15 years old, beautifully developed. The needle insertion sites have been changed up and down. There's some places where there's a little bit of skin depigmentation. But if he lifts the arm, the whole vessel is gone. So this is a low pressure access. That's why there are no needle insertion aneurysms. It's just a continuous enlargement of the vein. Yeah? So this is balanced. So here's just a table that I think you have in your printouts of the most common findings with this pulsatility, thrill, brewery, augmentation, collapsibility associated with a typical stenosis found by access type. And this is a table that, since we're putting so much effort into creating autogenous accesses, the most common findings with or associated with non-maturation, arterial anastomotic or juxtaanastomotic stenosis, outflow vein stenosis, or the presence of a large collateral, again, your findings, and the one that throws off most people is the large collateral, where everything is fine. You hear beautiful bruit, thrill, pulsatility is okay, but the key is you can't augment the access because the blood basically really dissipates. Now the last thing goes at this, we talk a lot about flow in dialysis access, so the last question goes, well, steel is not a problem with this type of access. Upper arm brachycephalic vein fistulas. Is steel a problem or not? Well, here's a case of another left upper arm access. Flows are 1400, with blood pressures. That's a middle of the road blood flow for an upper arm fistula. And he presents with these punctate ulcers on the hand, ischemic ulcers, we assume. And we document this by doing an angiographic exam where we inject contrast in the artery, and all the contrast in that upper little image goes into the access. Only when we occlude the access, which is the right lower image, can we see the arteries. So this is total angiographic steel combined with clinical symptoms of steel. So this gentleman has tissue loss in his fingers, and this needs to be addressed, and there's a procedure that's called banding that some of your patients may have undergone, where you, at the inflow segment of the access, you basically isolate the inflow vein, you put a little suture around it, you tie it over a spacer, either inside the vessel or outside the vessel, and then you get kind of a conformation change in the inflow segment, higher resistance, and then you reconstitute antegrade flow in the artery towards the hand, which is visible in the lowest picture. And that is usually very stable in steel. Like, it takes several years before you have to revise this again. Now, a different complication of flow can also be heart failure. So here you have an access, forearm access with a little bit over a liter of flow. Looks beautiful. He does have complete steel, where you can see that there's no antegrade flow towards the hand in the radial artery. But often that doesn't matter because you have an ulnar artery that perfuses the hand. So forearm accesses in general have much less steel, and it's much easier to manage if it were to happen. But in this case, for this gentleman, that amount of flow was too much, and he had decompensated heart failure with enlargement of his heart over course of 6 months. Flow can also be due to, or low flow can also be due to small arterial inflow. So you have a gentleman who presents with an access that has less than 400 flow and a highly calcified radial artery, which you can see at the bottom. And in this case, we dilated the artery, basically angioplasted the artery to a larger size, increased the flow, and then over time, this really became a very robust access. Again, even though he has calcified arteries, because of the presence of the ulnar artery, there's no steel in the forearm, and you have this very well suitable forearm access after years and years, with over years and years and years of use. Is flow everything? Well, flow certainly is important, but a lot of the things that we find, bleeding after needle movement, enlargement, skin thinning, layered thrombus formation, they're all really pressure-related phenomena. So here's a time lapse of an right upper arm brachiocephalic vein access, 2010, 2011, 2014, 2015. You can see that over time, with slightly elevated intra-access pressures, and I measured them, and this is before and after angioplasty, so 64 millimere mercury versus 49, you get these aneurysms that form. And if you don't do anything about it, you may end up getting these denudations of skin, and then you get rupture of the access, and your patient may expire if they make it from home. Other pressure-related changes over time can manifest like this. So you have an access here created before transplantation. The access is not used, and then transplantation fails, reinitiated, and there was an outflow stenosis, and you can see that the access under this continued high pressure ossifies. So there's a change of the cells, and they deposit calcium in the vessel walls, and this access is basically not usable anymore, because when you put the needles in, it crunches. There's a lot of resistance, and it doesn't have the elasticity to close off after needle removal. So here's an access. It's distended, the needle insertion sites. In this setting, if you occlude the flow, it completely collapses. If you do an angiogram, you can see that there's an outflow stenosis with indicated by the arrow. There's also and you have about 1,300 flow with a blood pressure of 190 over 90. So the mean arterial pressure is 120, intra-access pressure is 92 measured. If you do the angioplasty, you can see that collateral vessel vanishes. The flow is almost unchanged. It's slightly higher, but the intra-access pressures drop significantly. Yeah? So to treat this lastingly, this patient had a stent graft placed at that site of stenosis, and over years basically did not have further enlargement of the aneurysms. So for an outflow stenosis, the pressure change dominates the flow. The flow hardly changes, but the pressure goes up first. And so you, over long periods of time, if you just look at flow, you get enlargement of needle insertion sites and skin thinning. However, if you look at an inflow stenosis, then a flow change actually dominates the pressure. So here you have an access. They had difficulty putting needles in because the flow was so low that it wouldn't augment properly. And you can see the flows before angioplasty at 300, intra-access pressure is 20. You do a little bit of an angioplasty of the inflow, the flow more than doubles to 700, intra-access pressures barely go up. So that's the concept of, if you have an outflow stenosis, which is more common, that you have to look out for increases in pressure. What are normal pressures? They're in the 25 to 35 millimeter mercury range. There are few places that actually measure it, but if you get an access after angioplasty, you feel for the pressure, that can give you a little bit of a guide. So we want better flow, but better flow is really the right flow and the right pressure for the patient. Here's an example how much you have to do to get flow and pressures right. So this is an access created 10 years ago before transplant. 1 centimeter anastomosis. The vein develops down the forearm as well as up the upper arm. 4,000 ml per minute flow, highly pressurized access. And in order to get those large aneurysms reduced, you can do an aneurysm raphy where you resect the vessel sac and you make it into a smaller vessel. There are surgeons more and more in the US that can do this. And then you end up with a usable access after some banding, also with lower flows, and something that can actually be functional. But it takes 3 to 4 procedures. It takes a surgeon who's enormously dedicated to do this, but it can be done. A different approach, instead of aneurysm raphy, would be segmental replacement of these enlarged segments with biografts and the flow reduction by banding, but you always have to make sure that your outflow segment is not chronically stenosed. And in this case, a stent graft was used. So we've talked a lot about autogenous accesses and fistulas and grafts. And we'll switch now to talk a little bit about catheters. It's still over 70% of our patients start with hemodialysis catheters. So here's a 76-year-old gentleman who presents with itching around the access site. There's some discharge, although he's doing better on dialysis overall. So this is the photo. And the question is, yes, you suspect an infection, some discharge, but what type of infection is it? What do you do? So you give an IV antibiotics and local exit site care if you think it's an exit site infection. We'll look at that in this case. So the cuff basically is just inside of the exit site, and it separates a colonized segment from a sterile segment. So the tunnel is sterile, the skin exit site is colonized. So you want to make sure, is the tunnel affected or not? If the tunnel is affected, it's a different story. If it's only the exit site, you can usually treat that with antibiotics and rescue the catheter. If the second answer was, well, you can exchange it over guide wire if the tunnel is infected. So here's a patient who presents slightly differently, change in mental status. There's now tenderness over that erythematous area overlying the clavicle along the tunnel site. And if you then massage the tunnel towards the exit site, you get this purulent discharge that comes out. So here, the cuff is not preventing or is not sealing the exit site from the tunnel anymore, but you now have a continuous presence of infectious material along the tunnel. This cannot be rescued and requires really a new insertion of the catheter. Sometimes some people think you can exchange it. The European guidelines actually talk that you should try an exchange, but in the US, I think every expert would say that you have to take it out and you have to just get a new catheter in. Jumping to the last answer, so if the first image was a catheter-related bacteremia, then you could give IV antibiotics and catheter lock solutions. So there's a plethora of literature on catheter lock solutions and IV antibiotics and how it can rescue things. But if you look at the data that's available for reinfection of catheters with the same organism that you cultured and then stratified by antibiotics alone, catheter plus lock solution, antibiotics plus lock solution, or antibiotics plus guide wire exchange, or antibiotics plus removal and delayed reinsertion. Then for coag-negative staph, antibiotics plus cath lock works in about 3 out of 4 cases. So that's the only organism where you might want to do it. But if you really want the highest level of certainty, you either give antibiotics in exchange over guide wire, or you remove it while on antibiotics and then do a delayed reinsertion. The trouble with that approach is always that you give up a site often, and chronic catheter patients that have catheters for a long time, they occlude the internal jugular vein that the catheter is in. So every removal often means that you have to go to a new site, and they're often only 2, some patients 4. The other thing to think about with catheters is the fibrinous sheath that every catheter forms. And you can see that here, the catheter image with the fibrinous sheath. Dysfunction is often caused by this sheath occluding the site holes, and so that's the example of dynamic dysfunction, where they put the catheter basically works for a little bit, and then all of a sudden it doesn't when the patient moves. Here's an angiographic representation of the sheath. So the catheter is pulled back, contrast dye is injected, and all you see here is really the internal filling of that fibrinous sheath. And if you disrupt this fibrinous sheath, then you can see all of a sudden the vein ends entirety. Almost all catheters, if you look by autopsy, all catheters have these fibrinous sheath. Now, if you think of tunneled catheter infections, the tunnel extends from the skin into that fibrinous sheath inside the vein. So in this patient here, we actually pulled the catheter back, and you see all these concrements in that fibrinous sheath inside the catheter tunnel. And it's easy to envision that this is infectious material. So when you have an infected catheter and you pull out the catheter, you're actually leaving behind, in a sense, a niche in the fibrinous sheath where bacteria can sit. So that's partially the rationale. Well, if you have a fibrinous sheath and you have catheter-related bacteremia, unless you disrupt that fibrinous sheath during catheter exchange, you may then get cross-contamination to the next catheter, or you may have prolonged bacteremia even if you remove the catheter. And there's one study that actually has some data on this. So what we do is we always disrupt the fibrinous sheath, and no matter what the organism is, if it's fungus or if it's Staph aureus or so, we don't find relapses with the same organisms when we do that. Most of the catheters, or all catheters by EM, have a biofilm within 48 hours. And so those are bacteria that are not pathogenic in a sense, but they're there, and we don't really understand why this biofilm is then overgrown by organisms that cause infection. But all infections are, after 30 days, are really related to human behavior. So it's how the catheter is handled, or if the patient, him or herself, is handling the catheter in any way, but that's how bacteria get inside. There's a different kind of dynamic catheter dysfunction that is related to the tip position. Do you mind turning the computer back on? I think. Yeah. Well, no. It just disconnected. There's no image that I have. Oh, that's okay. I'll look at there. So basically, you have at the time of catheter insertion, the tip is located in a good spot. But especially on the left-sided inserted catheters, the thing that determines the tip position is the position of the cuff. So if you have somebody with a lot of chest tissue, you place the catheter in a reclined position, the tissue moves up, the cuff is fixed there. As soon as that person sits up, the cuff is pulled down, and what happens is that the tip is pulled back, and then it may get lodged in the sidewall of the vein. Yeah? So this is usually an early type of catheter dysfunction, and it happens just when they connect the catheter to the machine. One word about catheter lock solutions. They clearly work, right? I mean, so if you've ever been in a dialysis program that uses catheter lock solutions, your catheter rate will fall. The problem is that you get resistances. And you may get then bacteria that have resistance against gentamicin, against all the cephalosporins, against vancomycin, and they're all shared within your unit. So if somebody then gets an infection, endocarditis or so, you're then left without any reasonable choice, and all your usual antibiotics that you start treating an infected patient with may not work, and the patient actually may pass before you have the appropriate antibiotics on board. Summary catheter infections. We separate basically these 4 different segments, and then the treatments, vary according to site. If you have infected thrombus around the catheter, that's often a very dire situation where if it's true large amounts of thrombus that are in the heart and they're infected without opening up the chest and getting a thrombus out, it's very difficult to treat. Talking about catheters, apart from dysfunction and infection, the other thing that we often associate with catheters is central vein stenosis, as it also has an effect on the long-term surviving of the patient as they want to switch at some point to a fistula or a graft. So here you see the chest x-ray, and what I want you to look at is the position of the catheter tip. And you can see that there's this little electrode on the right lung, and right next to it is the catheter tip. So the 2 arrows indicate where the catheter ends. The blue circle, about 5 to 7 centimeters below where the carina, the carina is, where the left and right bronchi are separated, that's where you want the tip. And you want it there on the x-ray because the space is large, and you can have 400 ml of blood going into the catheter and 400 ml of blood going out of the catheter without doing too much endothelial injury on the vein and getting low recirculation. Now, this gentleman then has an access place on that right side, and he presents with arm swelling, and you can see that exactly at the side where those catheter tips were, that's where he gets his near total stenosis. And you can envision, every time they turn the dialysis on, it sucks in the endothelium, or it pushes out a jet of blood. So this takes a lot of work to fix. You have to put in stents and stent grafts, and they don't last forever. But I know that in this case, the access is still functional after 8 years, but it just puts this patient at a disadvantage early on. So summary at this point. Dialysis access dysfunction is chronic. So the most honest thing to tell your dialysis patients is when you get an access, you're going to chronic intermittently have some work done. And that's especially true as we're moving most people to fistulae. They often need work early on, and then you have less of it later on. Grafts still have a slightly higher failure rate, and even though with stent grafts, a lot of the venous anastomotic issues can be treated long-term, it still requires recurrent visits. Physical exam is really the key thing that you yourself as well as your staff can use to assess accesses long-term. The reason why we find accesses are failing is driven by elevated intra-access pressures so that the skin cover of the access is gone. Inflow is fine, the outflow is fine, but the skin wears out. And then you either have to rebuild the native vessel by aneurysm raphy, or if it is a non-autogenous access, you may have to put a new conduit in parallel. Good, so now we still have 5 minutes, and I do have some bonus questions. And so here we have a gentleman, so it's a 48-year-old kidney disease patient who has itching around the exit site, and the catheter has dynamic dysfunction. The question is, what do you want to do? And the options, I think, are IV antibiotics, local exit site care, exchange the catheter of guide wire, create a new exit site as the cuff is exposed and give antibiotics, or systemic antibiotics. I don't know if these questions are in the clicker or not. Probably not. No clicker questions. Good. Good. So in this case, you see this redness over the exit site, and you see the cuff exposed. So that little brown rim is actually the cuff that has come out. So this is a situation where that barrier that the cuff is supposed to provide is not there anymore. So if you see this, you should give an empiric antibiotic and send the patient for a catheter exchange, because this is kind of an impending breach of the sterile tunnel. Once the cuff is all the way out, well, then you probably, you cannot get away with exchanging it through the same tunnel. Now, in this case, because of the exit side looking relatively red and you have a beginning of an infection, what can be done is, instead of exchanging the catheter through this exact tunnel, you can get the catheter out by a small incision over the clavicle and then retunnel it, either more lateral or more medial, so that you get a new exit site away from this exit site. Yeah? While you do not give up on the vein entry site. So we've talked a lot about physical exam, and nurses often have a specific lingo that they present problems to nephrologists or to interventionalists. And so they may consist of needles are pulling clots, dark blood is in the circuit, high arterial pressures, dialysis filter clots during dialysis, high venous pressure, bleeding from access on non-dialysis days, positive arterial pressures, collapse of the access collapse of the access when they turn the machine on, or bleeding after needle removal. Now, this may be a multiple choice question. In the boards, they have this type of question too. So you have to sort all these causes depending on, you have to sort it to one or two of these listed causes. Is it an inflow arterial problem or stenosis? Is it a venous outflow stenosis? Is there misplacement of needle tip, or is there loss of skin integrity? Yeah. And I've color-coded them: red, blue, yellow, and green. And if you then look at the clinical presentations, we can resort them. High arterial pressures and collapse of the access are typically associated with an inflow stenosis. Yeah? The collapse is basically, it's just the flow is so low that the pump speed is higher than the flow, and you basically get collapse of the access around the needle. Sometimes what you can do is, clinically, if the artery can't be made bigger or there's no stenosis, you can turn the needle down, and that sometimes prevents the collapse around the needle. Dialysis filter clotting during dialysis can be with an outflow or inflow stenosis. It's basically a sign that you have recirculation, and you can get that with either low flow in the access, where you don't get collapse, or you can get this with an outflow stenosis. The dark blue in the circuit is similarly associated with a inflow-outflow stenosis. High venous pressure is pretty clear. You get a venous outflow stenosis. Positive arterial pressures, that's pretty rare, but it's basically, you can get positive arterial pressures when the inflow into the access is very high and you have a very severe outflow stenosis. And then you can get positive arterial pressures. I've only seen it 3 or 4 times, but the nurses are very alarmed when they get this. And that's usually due to a very severe outflow stenosis and best treated the same day. Bleeding after needle removal, increased intra-access pressures, it's usually an outflow stenosis. When needles are pulling clots, in my mind, there's no real clot in the access. It's typically that either the tip or the back hole of the needle is outside of the access. Yeah? And this can be due to poor augmentation, side branches, poor needling technique, the vessel being too deep, all kinds of things. But needles are pulling clot is basically the needle is not in the right position. Bleeding from an access on non-dialysis days, that's the one situation where you have to really implicate skin that is not intact enough. And then factors that come into this is if the patient is on anticoagulation, the INR is 7, Plavix, aspirin, etc. But identifying this is important because you need surgical revision. This is our last case. New PTFE graft placed 3 months ago. Spontaneous needle from the needle insertion site occurred during the night after dialysis. And you hear this. Patient is tachycardic because they lost blood, but there's also this discontinuous flow murmur, right? So Oh, sorry. Your 4 options were replacement of graft with only cannulation graft for better sealing after needle removal. That's a newer solution that you can, but in this case, you have an outflow stenosis, so you do an angioplasty. There is some literature that says you should place a stent graft because you get a much better result in the length of the approaching the stenosis, or you do a surgical revision by needle insertion site aneurysm. So, good. Thank you very much.